Good afternoon, everyone, and welcome to initial assessment or comprehensive assessment for NDIS clients. Also, this could be quite relevant for home care clients in the aged care sector as well, because they follow a fairly similar, if not almost identical, requirement. So just to let you know, there's going to be people coming in. We've got a massive 180 registered. Now, not everybody attends in person. Many people will want to watch by recording. So there could be people coming in is all I want to warn you about. So having said that, we'll go for about an hour. We're going to look in depth at a comprehensive assessment, which leads to a support plan. Yeah, no support plan should be written without a comprehensive assessment. So without further ado then, let's kick off. Now, what I also want to say is that you can put questions into the chat area, and Sheila will either answer them for you if she knows the answer, or ask myself. And let's just kick off straight away. So I'm Gina Ingrell from Effective Policy, for those of you who haven't met me. I'm a consulting company, NDIS auditor, community service standards auditor, retirement village quality auditor, and I have been doing that for a long time. And I'm also a provider myself. And I've worked in this sector for a very, very long time. So I've been an allied health professional since 1987. I no longer practice and haven't done for quite some time. But yeah, that's me in a nutshell. We've got Sheila here as well, who is a staff member with Effective Policy. So Sheila, put your hand up if you could. Do a bit of a wave with I think there's a little thingamy that can help you wave, just so everybody knows who you are. And there we go. That's Sheila. Okay. Right. So let's kick it off. So we're here to see assessment. So let's do it. Now, what I want to start off with assessment is that what I see a lot of is people having their sort of all different names. Oh, they'll call it an assessment form or an intake form or this initial thing or this screening or whatever, and they're asking the same questions on that, and then doubling up on a lot of those questions at the assessment. I want you to start thinking about it a little bit more streamlined than that. One of the reasons back in, I'd say, well, it was well before the NDIS came into, it was in the planning stages, but back in about 2009, 2010, it had become quite clear that the asking of so many questions so many times to so many vulnerable or stressed people, be that parents, spouses, or the actual person with a disability, was actually was exacerbating their own symptoms. And it was very stressful and very re-traumatizing for many people. And, you know, it is that case of when you're seeing somebody getting angry and losing it, there's a very good reason why in many cases I'm not saying that's acceptable. I'm just saying that when you're asked the same questions over and over and over and over again, I just want to walk away. So we don't want to do that. So part of trauma-informed care, part of logic and reasonable service delivery would say that we want to ask at intake or a screening just the questions that you need to know, that you can say, yeah, you know what, this is a person that I can deliver a service to, or this is a person who's outside my my service selection of, you know, I can't deliver to. So only ask those questions that you need to know to find out whether that person is someone that you can service. Do not send them out a comprehensive style assessment and then decide whether they can be serviced by you. That's not fair. So with that in mind, we've written an intake form, Now, I did this in collaboration with, I didn't sit down and want to make this up myself. We did this a couple of years ago. We had about 50 or 60 providers represented. And with that, we worked out yeah. So I'm unmuted now, am I? Sheila?
Should be good.
Yeah, okay. So maybe if I was muted, people didn't hear me. What part did you hear me up to until I was muted?
Right before this shared screen,
Cool, cool.
just
All right.
about 15 seconds.
Okay, so what we're doing is we're having a look at what you need to ask before you do some comprehensive assessment, which is going to take 1 to 3 hours of somebody's life they'll never get back. Okay, so let's think about trauma-informed care and service where you don't ask things that are unnecessary. So I want you to think about the screening part of your work, finding out whether somebody is the right fit for your service. Only ask what you need to know whether they're right for your service, and save that comprehensive assessment for the next step if they are suitable for your service. And as I was saying, 56 providers and I sat together and I asked them to tell me what were the deal breakers for them to be able to provide service to specific people. And this was the intake questionnaire that we came up with, and it only asks what's necessary. I'm not sure if you heard the part where I talked about the stress and the frustration and the exacerbation of symptoms that people have when they're asked to do assessment forms, and then be turned around to say that you're not suitable for our service. So please avoid that. So that's the intake. We won't go through the intake. We're going to jump to. You will get this intake if you decide you want to buy the tools, but this is. We won't worry about this one. We're going to jump straight to the assessment now. Okay. So just bearing in mind, separating that screening of your client to see if they're right for your service and you right for them, from the comprehensive assessment part where you mean business. You're actually going to onboard the person. You're not just going to assess them with 10 pages of lengthy questions just to be able to say, oh, I'm sorry, we can't deliver that one. We're not registered for that, or this isn't what we do, or that's out of our registration. So with that in mind, let's move straight to the comprehensive assessment. And I say comprehensive assessment leading to the person-centered support plan because, and I know we're going to have a range of people in this audience, and the people watching this now and watching it later, and people who'll be watching it in the future via my LMS. But what I want to say is you can't have a person-centered plan or a person-centered anything if you haven't asked lots of questions, okay? Now, over the years, I am starting to see a marked difference in the providers in the market who are learning that they need to be comprehensive in their assessment. But we've still got a high number of percentage of providers who don't know. And much of that comes from the fact that this market, this NDIS market, and I don't have statistics to say this, but I would say ad hoc, what I would say is 80% of the NDIS market do not know what they're doing. And so it's a big, steep learning curve, yeah? So we would say that still 80% of people are not collecting the information that they need to. For registered providers, eventually they're made to. Eventually, one way or the other, there's the carrot and the stick works. Now, some clients, some providers respond well to the carrot as well. And some people are just incredibly ethical and want to do it right. For anyone who's unregistered and ask me, do I need to have policies and procedures and follow these things? Well, you know what? The law isn't telling you that you have to yet. It's going to, but isn't it the right thing to do to have them? And it is, okay? So there's right and there's wrong. There's ethical and there's unethical. Yes, you should be doing this because if you're taking people into your care, you're responsible for what happens to them. So no person-centered plan can be created without asking lots of questions. Another word for that, comprehensive assessment, okay? Now, this has morphed over the years because we've seen changes to the standards, and we've seen changes to the standards in response to deaths in care, preventable deaths in care. We're not talking about people who died of natural causes. We're talking about people who died and their death was preventable if organisations had known what they were doing, or if they knew what they were doing, had actually done what they were supposed to do. Yeah. So we're talking about changes that happen ongoing. Now, sometimes I'll make changes to my documents just based on a lot of information I see when I'm working with providers day in and day out, or auditing. Sometimes they won't be in response to our legislation. They'll be in a response to, I can't believe I'm seeing this again and again and again. So really, these are really honed in and really good tools. And my tools haven't had a non-conformity in so long, I can't even remember the last one. That doesn't mean I'm worried about non-conformities. We stand behind every single document we make for their lifetime. And I consider any suggestion that's a non-conformity, and I can see that it is with the standard, which I said doesn't happen much, I'll fix. And I'll take on suggestions too, opportunities for improvement. But I won't just take on anything that some auditor says, you know, do this or do that. If it's a good one, of course, I'm going to take it on. That's continuous quality improvement, isn't it? So we've all got to be open to improvement. So in saying that, we've got to look at the framework that we're collecting information in relation to. And I want you to be able to put on your nuance hats and your logic hats and your reasoning hats. And now that's the thing that I don't see the most, and I think it's probably the biggest risk in this sector, is a lot of people, not all, haven't learned to use logic and reasoning in what they're doing. So when I give you an assessment that is able to cater to the most complex client that you could possibly have, but you only deliver services in a low risk area, then you have to put on logic and reasoning hats to know what applies to you and what doesn't. Yeah. So you could think that through. If you're only delivering, well, if you're a verification service provider, you're probably not in this meeting. But if you are, and you're an allied health professional, a large majority of this matters to you too. But there I would want you to put your logic hat on and reasoning hat on and go, well, you know what, I can see that doesn't apply to me, so I'm going to leave it. And you know what? Leaving something empty or unanswered is okay if you've used logic and reasoning to decide why. But I want you to write in there, not applicable because X, Y, Z. Because if your auditor sees that, if we see a blank row, a blank column, or a blank subject field that's got a question, we're going to give you a non-conformity because it's not implemented. You can't expect us to guess that it was not applicable, and we won't, because that's not good information standards, and it's not good clinical governance. So we're going to want to see that you have either filled it out or you've given us a reason why you won't. And if the auditor finds that that reason isn't reasonable, they'll let you know, and just as we will as in our consulting space as well. So this is logic, reasoning, and understanding the nuance of the actual role that you're doing in assessing people. You have to use these things. You have to think them through, all right? So in starting at the beginning, we always start now with, is this a SIL client? Because clearly that is the highest risk that you can get. And we need to know straight up instead of finding out later on, okay? Reason it's right up here, right up front, is because every SIL client needs something like a CHAP. Now, get this, CHAP was around before the NDIS. It was around I can only speak for New South Wales services because I worked for non-government and government, and everyone had to have a comprehensive health assessment plan in the New South Wales government ageing, disability and home care sector. But there was nothing when I came back years later into this NDIS space and saw nothing. Nobody had mandated that anyone be having some, overall health assessment sent off to their doctor or monitored. So only a few years ago, during round about, the last changes that came in, which was in November 2021, due to the preventable deaths in care, a CHAP or similar was mandated. So now we need to do one. So we want to know that up front, because then you're going to know, yeah, I've got another thing to do after this. And I also want you to use logic and reasoning about this. Yeah, these take time to do. Yeah, people get a bit frustrated. That's life. So what are you going to do about it? What are you going to do about it? What are you going to tell your staff to do about it? Well, a couple of things are, don't do it all at once. If somebody doesn't have the resilience to sit through it all at once, don't do it all at once. Or the other thing would be, do the important things that if it's an urgent situation and you need to onboard this person who's homeless, do what you need to do, because you can see their risk tolerance, their frustration tolerance is wearing thin, yeah? So you've got to use reasoning, logic, and nuance of what you're doing to be able to figure out when you're pushing someone too far, how much is all right in one go, etc. Okay? So, and I'm saying that because I get people coming back saying, oh, God, my staff are all complaining. Of course your staff are complaining. If they were doing a one-page document once, or a two-pager at the most, if you give them a 6-page document, of course they're going to complain. But you as the boss, the manager, or the owner, you need to know how to manage that. You need to know how to help them to combat their frustration tolerance or their lack of knowledge about what is needed. Tell them a couple of stories about what happens to people when this doesn't happen. Talk about the preventable deaths that have occurred because someone didn't do a proper assessment. And the statistics say across all of health and all of human services that the biggest cause of problems or incidents, reportable, serious, any incident at all, and I've worked in New South Wales Health in the incident response team there. I've seen the data. I know the biggest problem is that somebody didn't assess somebody properly. So that is our biggest combating tool to things going wrong, okay? We have to know up front, okay? So use whatever you have to educate your staff. If your staff, still are jacking up about too much work, well, sometimes they're not worth having, but many are salvageable, okay, with a little bit of information, some support and some supervision. So it's really important to know, second up, and these are in this position for a reason, transitions, are they coming to you from hospital? Because if they're coming to you from hospital, you want to have a discharge plan, okay? All right. And if they're coming to you from another service and these people are complex, especially a SIL service, you want them to come to you with a transition plan, and you are well within your legal rights to say to the previous provider, I expect a transition plan outlining the risks for this person that you know of and in the transition process, because you need to know what's coming to you and what that person's risks are so that you can have a bit of a risk plan. Because the other data shows that the biggest risk in people's lives where things go wrong is when they're transitioning from one service to another. And we know that's happening a lot in NDIS, because we know that it's an open door. People can go from one provider to the next. So it's far more risky than it was in the old services before NDIS, where there was only certain providers that you could go to. So, you know, you may only have 2 in your area because they're great big block funded not-for-profits. So it didn't happen quite so much, but the risk is enormous for people coming from one service to another. And especially when they're coming from one service to another where someone had absolutely no experience in one of those services. So they don't know what they don't know. So SIL, transition, really important information to have up front, because you know, then you've got some big pieces of information. For example, if you've got a transition plan, and don't be coy about asking for one. You're legally able to ask for it. And when you're sending someone to another service because they want to leave your service, do the right thing and just write one. Yeah, that's the right thing to do. Participant details, I don't think we need to go into that. I think they're self-explanatory. Now, client matching, you might manage this in all different ways. You may do it further down the track, but I suggest that you do it up front, because you can't say that you know what's a good match for that client unless you've asked it at assessment, can you? So some people will have a gender preference. Some people you want to match up with their hobbies, etc., and preferred age of staff, etc. as well. Now, when it comes to SIL, we have a whole other matching process for that, because this is where a lot of the deaths that are preventable do occur as well. So that's a bigger assessment, and it's multifaceted because there could be other people in the house as well. But this is just your general service preference, client matching, etc. And the other reason this is here is because there's a standard that asks about it. So do you know what? I'm a really lazy person, and I think that makes a really good quality manager, because you're always looking for the easiest way to do something that makes it work well. Yeah. And so as an auditor, I just wanted people to show me things that were so organized and systematic. So everything should go into the assessment form, because here's the answer to an indicator, right? You know, have you found out what this person needs, et cetera, et cetera? Yeah, here, see, this is where we ask. Have you taken care of, how do you take care of that person's prevention of deterioration of their health? Here, we do a chat, yeah? Do you know what this person's risks are that are coming to you from another organisation? Yep, because we've got a transition plan, or we're sending them out with one when they're leaving us. All right. So these are more just, we don't need to go through nominee and carer. Client matching, GP details, absolutely. Now, when it comes to, I just want to mention, when it comes to the CHAP and you're sending a person with a CHAP off to their GP, please know that if you send them off with that CHAP and you expect them to write all the details in, they are going to say, I don't want to do it. And so would I. So what you have to do with that CHAP or anything else that you're sending them with is you have to fill out all the details that you possibly can, so that that GP has the minimal amount of information to fill out, okay? So that means that you would go through that CHAP and you would put all the details that you know about that person, and certainly not expecting the GP to put names and addresses and dates of birth, and you can make it easier for that. So the more you do that, the more your GP is going to be on board with you, okay? So, GP details, communication needs, really important about communication needs, because it's one of the things and one of the reasons, causal factors for preventable deaths, is that people were unable to communicate their needs to people about what the pain they were in, what they were feeling, how unwell they were, etc. So communication is incredibly important. We know the standard stuff, of course, from a cultural background, of course, from a spoken language, of course, from a sensory point of view, but also you want to be able to ask as well, be aware about how someone is going to communicate with you if indeed they can't communicate at all, like Anne-Marie Smith. And she wasn't able to communicate well, but nobody asked what was a good way around that. Yeah. So that was yet another preventable death. So I think that if you always think about this in a conversational manner, I've seen people like a robot ask every word. Now, this is where it comes to logic and reason. Yeah. So your logic and reasoning skills for yourselves and for your staff are really important. If you read out, is there anyone you want assistance from while we develop your, you're going to lose them. So just conversational style. Is there anyone you want involved with this plan? Reword things. You don't have to say it exactly as it is. If you know the answer to something, jump ahead. Try to go into your comprehensive assessment appointment with everything you already know about them, probably from intake or maybe from something else, already completed. Don't ask again if you already know it, if you don't want to see people frustrated. So people involved in the development of the plan, this is another indicator in the quality and safety standards. Health and medical, this is now we're coming down to the real nitty-gritty of the really important stuff and some of the stuff that has caused preventable deaths, okay? So we need to know whatever we can possibly know about this person's health and what makes it complex. Would anyone like to tell me what the definition, and they're loosely, they're not kind of put in a Webster or Merriam dictionary, but who wants to tell me what a decent definition of complex health is? Any takers?
Yeah. Feel free to unmute if you want to share something.
You can use the chat or you can give me a voice. Nobody wants to have a guess what the definition of a complex health situation might be. Come on.
A client who has episodes of fitting, asphyxia, which could lead to a medical emergency.
Yeah, absolutely. And look, complex, I want you to look at it like this. It's not one, there's a few facets to it. Complex is not black and white. It is anyone that has more than two or more diagnoses, okay? And you know that your guys are coming to you because they already have a disability. And so there's going to be a diagnosis of some kind there, yeah? And two or more means that it's going to be complex. So when you've got 3 and 4 and 5, you're looking at complex. Now that's conditions. I also want you to think about complex in the broader terms of it. So, having worked out in many other sectors, complex is also if somebody can't speak the language well. Yeah, so if they come from a non-English speaking background and their English isn't good, care is going to be more complex. Yeah, unless every single person in your organization speaks that language, and quite possibly everyone in their closer circle outside of that. So it can come down to language. It can come down to embroilment in the justice system. So anyone who's been to jail, anybody who's on probation, anyone who's has constant arrests, even though they're not put in jail. So embroilment in that. And people who come from families where the family have lots of issues. So I want you to think of complex care and conditions, and then the environment of complex care, which could be any of these other things that I said, because you can bet $1 million if you've got someone, let's say you've got someone who only has mild autism and mild intellectual disability. But let's just say that their family are so dysfunctional in the mental illness, the drug and alcohol use, the unemployment, et cetera, et cetera. Is this client going to present to you as a complex client? I think yes, because your hurdle is going to be that family. Yeah. And it might not even be, I've given you really extreme circumstances for that family. There could be a situation where the family don't have any of the drug and alcohol issues. They're not poor, but let's say they're so stressed and so uneducated in terms of autism and disability, and they've got funny beliefs about not wanting to be part of the welfare system and not wanting to seem like, you know, that can be complex. They can be your worst, not the worst, what's the word? Your biggest hurdle and barrier. Yeah. So I want you to think of complex. Yes, it's multiple conditions and it's these situations, and then it can be something you didn't even expect. Because if you can't get that person to their appointments, you've got complex. And sometimes the family can be the barrier. Okay, so enough about that, but I want you to think broadly about complex, all right? So asking about assistance down here is very much an indicator on the quality and safety standards, asking what they want help with, asking what they don't want help with, and always remembering, don't help someone if they didn't ask for your help or they didn't accept your help. Okay, so we want to be able to help people to, or support people to do for themselves where possible. And I know, having been at the very, very bottom of the support work food chain, I know how much easier it, and being a mother as well, I know how easy it is. It's so much easier just to do it. It's so much easier to do it for them, but that's not how people learn, and it's hard work. And you know what? You may not always get that right. You might be so tired one day that you just do rather than do it for them because you're having a bad day. And you know what? Every now and then that's okay. But on the whole, try to teach people that you're working with that it is important for people to have an opportunity to do for themselves. And I really want to stress this, that people are being paid to do a job, and it's okay to expect them to work. Yeah. Rightio, health and medical, more about health and medical. Of course, we want to ask very, very specific questions around medication, because I would say out of the audits we do, 30% of people think they're not, and that's a third of providers, 30% of people think they're not assisting with medication. Do you know why they think they're not assisting with medication? Because the person is only being reminded. Being reminded is assisting with medication. Yeah. Okay. Now, I didn't read any of those answers in there, and I just want to. I love this. Oh, you've been answering people. That's really good. A mix of care needs. Yeah. Conditioning and environment. Excellent. So I want you to keep really thinking of complex care, not just in terms of a diagnosis, but in terms of environment, what you're dealing with the family, etc. Good. So that's around medication. So FYI to everyone listening now and everyone listening in the future, and by recording, you know, later on this week, 30% of the clients we audit think they're not assisting with medication because they're only reminding, all right? And you are assisting with medication if you're reminding, and all of the rules apply to you. But of course, we do want to build up their ability to do so for themselves when possible, as much as possible. And like I said, I'll be the first to put my hand up. It is easier to do it than to help someone to do it. And as long as we're trying to, you know, work with people, helping them be enabled as much as we can, bearing in mind we're all human and sometimes we're tired. Yeah. The physical environment. Now here we come down to, you know, one of the biggest reasons that some of the changes came out, and the, you know, the Anne-Marie Smith, we should call this the Anne-Marie Smith condition, which is about living alone, and then progressing on to if somebody lives alone. And also there's other things about physical environment as well. I want you to be looking in their home to see, does it seem like an abusive place? You know, is it a safe place for that person? Be aware of that as well. But talking about the living alone risk assessment. For those of you who have some education around this and you know how to tell straight off the bat that it's not a problem, that's fine. But there's very few people, but I would want you in that case to write why it's not a problem. But for most, I'd say 90% of providers, you need to go progress yourself to a living alone risk assessment and go through those elements to make sure that you can safely, that you identify if the contributors to what happens to people when they're living alone and there hasn't been a proper risk assessment. You want to make sure that you can manage that situation and identify which ones apply to this person. Yep. Mobility and transport. Well, I don't think we probably need to have too much to say about that, but make sure that, I think what I do see at audit in site audits is sometimes mobility equipment on hire or purchase is not serviced regularly, and it should be. Well, has to be, really. Living skills, I think that it's probably something that everybody asks anyway. So family relationships and contacts. Now, what they found in the report, going back to 2020 now, was that because of the new market that the NDIS brought in, many people were given all these new fun things to do, but they weren't being helped to maintain their previous ones, their previous friendships, their previous communities. We don't just go in like a bull in a china shop and make things happen the way we think they should happen. What did the person have? What can we maintain for them? And that was one of the findings from that report, and therefore why this indicator is now in the quality and safety standards. Find out what they already have and try to keep that maintained, rather than you making new contacts and new hobbies and new everything else for people. Of course, the sexuality and intimacy is important, so that's there. I think that sort of speaks for itself. Now, I know that there are some cultures that don't really like homosexuality, etc. I'm one to call a spade, so I'm not going to veer away from that. Bad luck. You shouldn't be working with someone if in any way your belief systems are going to be impacting on them. So maybe that's not the client for you, because we don't need to have anyone feeling less than perfect about themselves. So if that's not the sort of client you can work with, please don't. Let them be worked with by someone who will respect them for who they are. Interests, leisure, community groups, once again, speaks to that standard about keeping people involved with who they came to you involved with. Their cultural and spiritual identity. I want to flag something here of interest, was that I was auditing someone and they had lots of cultural needs for people from non-English speaking backgrounds. And when it came to one of their clients that had, was, probably like me, like 7th generation of Australian, I said, what about the culture there? And he goes, I said, it's a blank. And he went, oh, there's no cultural need. I went, are you serious that like there's no cultural need for someone who's, however many generations, just because they speak English and no other language, especially when the owner of that business was actually from a non-English speaking background themselves. And I just want to put forward, everybody has a culture. Everybody, if you fed me food from a different culture every single night and all I had was that culture in my face all the time, I would feel like I wasn't on this planet. And I think we just have to find out what it is that people, what's their culture, whatever it is. Yeah. Reasonable adjustments, that is another indicator. So where there is something that's needed, you know what, it's not always as serious or big as this ramp or something. We've got that example. Does the client need a ramp? Well, people seem to be able to get that. They can get that. They can understand that somebody needs this physical adjustment. But there are much more nuanced things than just that. I'm just going to go back to the chat. Yeah, Aussie culture. Thank you, Zoe. Yeah, this is good, making me think much more about what we're doing. I'm so glad. Good. Because once a time when I started 25 years ago, I mean, I was an allied health professional before that. But when I started in these sectors, we didn't have such a lot of non-English speaking background cultures in such numbers. And there wasn't really, it was quite the rarity to have the non-English speaking background or cold when it came in later. Everything was geared towards, making that right. And all of us, well, we were still just, we had 80% of people who were, Australian born and Australian raised with, a few generations of Australians. And so we've got to keep up with the changes, but remember, don't leave the Aussies behind in that, because it seems like so much is geared towards managing cold communities that we kind of forget about those of us who, have that sort of true blue, if you like, Aussie culture. So let's not forget about that. Let's remember everybody. So another reasonable adjustment that might be nuanced, who could think of something that's not as big and as, as and in your face as needing a ramp? What's something else that might be a reasonable adjustment that you might have to do for somebody? Yeah.
Oh, Gina, right before we jump in, there's a question from Courtney and Carrie. Are you able to explain the
Yes.
relevance of the reasonable adjustment section to a direct support provider or support?
Yeah, okay, so something might be that, so we're talking about that something really tangible, isn't it? You can sort of touch that ramp. But let's talk about something that might be that somebody's volume, here's some of the things I hear, somebody's volume of their television really annoys the next person in the room, but if the person doesn't have that volume, all hell breaks loose. What can you do? What's the reasonable adjustment you're going to have to manage for either one of those people? So some of the reasonable adjustments can be quite nuanced like that. So they might be around TVs, putting TVs in, taking TVs out, volume, air conditioning. A lot of people have overheating and their body overheats. So there's all sorts of reasonable adjustments. So it's not always a tangible, in fact, very, very infrequently is it a tangible mobility ramp or second wheelchair or something like that, or shower rail. It's often something far more intangible. Yep. Just need to chat. Yes. Well, reasonable adjustments we would expect anyway. Every single dwelling should have the temperature on the taps. And every single dwelling, so that wouldn't need to be an adjustment. That's an expectation, and those taps should be monitored. Their temperatures should be checked once a month. But there could be other anyway, I think you get the drift with that. Now I'm adding this because it's important, and I do believe one day that they might add it as a standard. They haven't entered it as a standard, but it should be there, and it's called end-of-life care. So when people come in as a 24/7 client, it's important to at least start the conversation about end-of-life care. Yeah, because they could be with you for a long time, or they could be nearing their end of life, but it's never too early to have the conversation. And yes, it can be uncomfortable if you're not used to it, but you will get used to it. And if you chose to work in this sector and do this work, then you need to start getting used to it. Some things are uncomfortable. Sexuality questions might be uncomfortable, but this is the sector you work in, and these are the questions we need to know, because nobody should feel they need to hide their sexuality because somebody didn't want to ask about it. Yeah. So end of life, really important too. Now, come down to one of the most important things, which has resulted in many incidents and preventable deaths in care, which has been no recorded process or response for what you're going to do in a medical emergency. And I don't mean just the general someone falls over anyone, whoever it was, and you call 000. I don't mean that. I mean that every person will come to you with a set of circumstances that you can predict what some of those possible medical emergencies might be for that person. We're not going into the unknown and the we're not going to be coming up with theories that are so far from what the truth could be. People who've had strokes, who have cardiovascular disease, who have epilepsy, etc., they are going to have known, they're known factors. So whatever those person's complexities are or conditions are, it is expected of you that you will, put down what the known medical condition or psychiatric condition is, B, find out what the communication barriers that might impede that person are, because this is the key as to why people die. Remember the bowel obstructed person? And I'm sorry, I can't remember their name. It was horrible. They were in such pain and they died. They couldn't tell anyone. It's a preventable death, yeah? Column C, what are those signs or symptoms to look for aligning to column A? And column D, what is the agreed response up front? And there's, of course, you need to review those things. Now, the thing with this is, like anything, if your staff don't know about it and you've done a perfect responding to a medical emergencies for every one of your clients, that your staff are never going to see this, then you may as well scrumple it up and put it in the bin. Because if they don't see it, it's of no use to anybody, okay? So that's the implementation. This is the doing, and then comes the implementation. This information needs to be available to people, all right? So that is, oh yeah, and then you come down and you would write your person-centered plan. Now, it doesn't have to look like that. It can look like anything you want. But all of this information that we've collected is going somewhere, and it's going to work out the goals. What are the goals for that person? Well, first of all, you look to the goal that's in their plan, the broader goal. And it might be that broad goal, learn to live independently. Okay, well, that's a big one. How are you going to break that down for them? And that's what this is doing, breaking that down for them. All right, so tell us that actual goal. So do they have an example of what this would look like for them? All right. So the NDIS plan might be in goal type, it might be learn to live independently. Then what is that person or that person's carer, or what together can you come up with that kind of reflects that, in their own words, based on the assessment you've just done? Here's the important part that people aren't doing, and it's in the standards. What are the goals? What are the challenges to these goals? What are you flagging them as straight up? And what is the plan to assist that person reach that goal? In other words, how are you going to work to combat those barriers? Yep. And that's it, peeps. The more information you collect, the better your person-centered plan is going to be. But remember, if you withhold the important information from the people who are going to be caring for that person, you may as well scrumple it up and put it in the bin, because they're just flying by the seat of their pants. So that's where care meetings come in, and, introductions to that client and what their needs are, etc. You wouldn't expect to go to hospital and not have the nurse come in and say, well, this is such and such, and they've got this and this and this, and this is what we're going to be doing with that person. So everyone needs to be on the same page. So there's a few questions in there, so we'll go to that. Oops, something is going on. Right. Okay, well, I think if we've got any, questions, because that is our comprehensive assessment done. It looks like you've been handling all the questions, Sheila, making me redundant. That's good. Does anyone have anything they want to ask, contribute, add? The one thing I will say at the end of this is I'm assuming everybody knows that your assessment must be done at least annually. I'm not talking about the NDIA assessment. I'm talking about your in-house assessment. It must be done at least annually, and your plan must be done at least annually, unless there's a change of someone's circumstances. and then it should be done more often. But you can update it when you feel it needs to be updated, and essentially, you know, it's really just an updating of the information, checking that it's all right. You know, think about, you know, much like when we, you know, I used to be a dental practitioner, and you know, when someone would come in, what we had to do was ask, are there any changes to your medication? Are there any changes to this? Are there any changes to your health? Asking all those questions, because you've got to recheck some of that information, and think of your reviewers checking all of that stuff, making sure there haven't been any great changes to this person's social or economic or health situation. It's just what we do. It's just due diligence. It's risk management and clinical governance.
We have a few questions in chat.
Yep.
Gina, starting with Jeanette.
As an unregistered provider to people with a disability, am I allowed to ask carers to share the NDIS plan so that I can create support plans? I would just ask them to share the goals. People don't like to share the money. So ask them to share the goals with you. Or if they don't want to share the goals, just tell them, could you just tell me what the goals are so we can better help him or her. And the other thing is, remember, you all have the right to know whether there's enough money in there to actually pay for the services. So my advice to you is, if you're unsure and you haven't got a situation where the plan manager will help you out with that, then I would suggest that you know, I just wouldn't take a client unless I knew that the funds were there. It's not a charity. Gina, where in the plan would you identify address complexities linked to behavioural needs? Well, that's in the risk assessment. See, this is your comprehensive assessment. We then go on to do a risk assessment, which is a whole other 1 hour that I'll be doing next. So this is for general assessment, and then we go on and do the risk assessment. Yeah. So we will have already covered off, if there's behavioural issues, we will have covered off in communication or under pain areas or conditions where there might be behaviour in the way, but it doesn't matter because we're going to cover it in the risk assessment. It's just too much to do in one go. Well, private info, the goals, if they want a better service, they'll tell you what the goals are. If they don't want a better service, that is their choice. But the funding, some people will show you, some people won't. And I don't blame them for not sharing the funding, but you have a right to know if there's enough money. So if they don't want to show you that, I just won't see them. And eventually they'll get the hang of it that, you know, you can't just take on anyone because some people don't have any money left. Are we able to have copies of your template for the risk assessment? So we'll make available at a very discounted price the intake and the comprehensive assessment and support plan. But the next session is going to be risk, and believe me, it's a session on its own. Yeah. Yeah, we'll do the next one as risk assessment. Because really there's a general risk assessment, and then there's several other there's several others like the risking the home alone. Hopefully, if I make it an hour and a half, I think we should get through all of them. Yes, well, the email for the next seminar, it'll come out if you registered for this one. Usually it lets people know. If not, you'll find it by the same channel. Thanks, Jeanette. It was a pleasure having you. We will send this out. It'll be valid for 30 days. Watch it with all of your team if you want to, or just your clinical staff or whatever you like. And yeah, watch out for the next email. I've also got one coming up with my, I have a marketing person, and I've persuaded her to do a free marketing webinar for people. So that's our next one, and it's next week if that interests you. We'll probably have risk assessment the following week, I think. I hope that was good. I enjoyed it. Look, some of you may already have one that works perfectly well and you just weren't sure why you were asking the questions or whether it was okay to leave certain things. And if that's the case, great. I just hope you were able to take something away from it. Pleasure. Thanks everyone for coming. Have a great afternoon. See you next time. Thanks, Sheila. Whoops, I'm in the chat. Pleasure. Thank you. Okay, Sheila, talk to you soon.
All right. Bye,
Bye.
everyone. Thank you for joining.
Bye.
Bye. Thank you.
Bye. Bye-bye.
Bye.
Bye, thanks.
Bye. Can't seem to, it won't seem to respond to me.